Thank you for joining my presentation on non-invasive ventilation versus high-flow nasal cannula for hypoxic respiratory failure. My name is Terrence Shenfield, and I am the co-owner of A&T Respiratory Lectures, and I'm happy to bring you this presentation. So we all work in healthcare. We could either be a nurse or a respiratory therapist, and we always come across patients who are in hypoxic respiratory failure. The question is, what do we grab? Do we grab a high-flow nasal cannula or do we grab a non-invasive ventilation? And which one is better for the patient? There are many studies out there that said one is better than the other. There are different types of medical conditions that lead into hypoxic respiratory failure where one could be better than the other. So at the end of this presentation, you're going to have a good handle exactly how a high-flow nasal cannula works. I'm sure you know how a non-invasive ventilator works. And then I'm going to also be talking about hypoxic respiratory failure and when to apply one versus the other and where is the evidence supporting one versus the other. In today's objectives, we're going to be talking about what is hypoxic respiratory failure. We're also going to be talking about the role of non-invasive ventilation in the management of hypoxic respiratory failure. We'll also be talking about the role of high-flow nasal cannula in hypoxic respiratory failure. Finally, we're going to be talking about some risk factors with the use of non-invasive ventilation. And we're going to also be describing a tool called the HOCKE tool, which is used to determine whether non-invasive ventilation is working or not. And because there's risk factors involved, the longer you keep someone on non-invasive ventilation without intubating them, the greater the mortality. And this tool is a great tool to determine when to intubate and when not to intubate when NIV fails. Hypoxic respiratory failure could be described as an acute condition where the patient has an increased breathing rate and low oxygen saturation. To measure this, the PF ratio has to be less than 300 and the respiratory rate has to be greater than 25. Typically, the blood gas pattern of these patients is hyperventilation with hypocapnia. Basically, they're panicking because they're having a hard time oxygenating, so they hyperventilate, and as a result of hyperventilating, they get hypocapnic. So the problem with that, they eventually tire. So the hyperventilation that is caused by the anxiety of not breathing right, eventually their respiratory rate slows down and they start retaining CO2, which may lead into some form of intubation, non-invasive ventilation, or the use of high-flow nasal cannula. As I mentioned in the previous slide, with hypoxic respiratory failure, typically you hyperventilate, and as a result of that, your CO2 levels go down. But as you get tired, you have impending respiratory failure due to the fact that, you're tiring out, and then you become hypercapnic. So the goal would be to give the patient some oxygen prior to them getting there. If they're already starting to get hypercapnic, then you have to treat them with a certain modality, which we'll get into. But if they're not hypercapnic and you can get them some oxygen therapy in, the high-flow nasal cannula is a great tool. The rationale for oxygenation includes improving the symptomatic treatment of hypoxemia and to support the high load of imposed respiratory muscles, because like I said, the body normally responds with hyperventilation. So let's list some common causes of hypoxic respiratory failure. And there are many pulmonary conditions that can lead into it. Obviously, hypoxic respiratory failure can occur with COPD. But also with COPD, you're going to have CO2 retention. This could differentiate between what kind of therapy you're going to use, non-invasive ventilation versus high-flow nasal cannula. You also have pneumonia. Pneumonia also contributes to hypoxic respiratory failure, and it could also increase the work of breathing, which could retain CO2. Pulmonary edema, pulmonary fibrosis, these are other common disease categories. With pulmonary fibrosis, because of the thickening of alveolar tissue and because of the distribution of gases across that alveolar, a lot of times you have both a combined hypoxemia with hypercapnia. Asthma. Asthma is a disease where you get constriction of the airway or you have secretions. What happens is the work of breathing increases, so they could be hypoxic as well as CO2 can retain. Pneumothorax is another example of hypoxic respiratory failure. Pulmonary embolism, that can be a result of both hypoxic and also hypercapnia, and also pulmonary hypertension. So the clear answer here is many of these conditions can lead into hypercapnia. So initially, a high-flow nasal cannula could be very useful at the beginning, but eventually you might have to go into non-invasive ventilation and even potentially intubation. So it's kind of tricky, but most of these conditions will absolutely lead into hypoxic respiratory failure, and you need to have some kind of intervention to manage it. So let's get a little bit into the technical characteristics of non-invasive ventilation and high-flow nasal cannula. You need to have a little basic understanding of each device and how it applies to hypoxic respiratory failure. The technical characteristics of a non-invasive device is that it delivers spontaneous positive pressure to the respiratory system into the lungs via an external interface. This positive pressure can be delivered via the ventilator, via a face mask or nasal pillars. It also is connected to a humidification system, especially a heated humidifier or a moisture exchanger. Also, it can be delivered via a ventilator or a standalone BiPAP system. I'm not going to get into the technical aspects of the setup, but I'm sure you all know about non-invasive ventilation, IPAP over EPAP, and so on. But this is the basic setup and the technical characteristics of a non-invasive ventilation device. The technical characteristics of a high-flow nasal cannula varies from manufacturers. Basically, it is a simple system consisting of an air-oxygen blender directly connected to a flow meter. The flow systems will go up to 70 liters per minute, and it can give a mixture of gases up to 100% oxygen, and it's routed through a heated humidifier, which makes it completely saturated with water with a relative humidity of 100%. The whole point of this, the high flow of gas up to 70 liters per minute, because it's completely saturated with water, actually makes the patient a lot more comfortable than you would think. I've tried it on personally, and it really, you can never tell you have such a high flow. It can be set up via a simple nasal prong setup. It really works out very well that it washes out all the CO2 from the dead space of your lung, and it delivers a high portion of FiO2 to the airway. So this is the technical characteristics of high-flow nasal cannula. I could get into a lot more, but I'm assuming you understand those basics. I wanted to go into some of the physiologic effects of each type of device where the high-flow nasal cannula differs from the non-invasive ventilation in regard to thoracic compliance and breath delivery. Here's how it goes. The high-flow nasal cannula has a set flow system, so you set a constant flow at 40 liters per minute, 50 liters per minute, whatever, and the flow is exactly the same, but the pressures vary in the airways according to the patient's breath effort and dynamic thoracic compliance. So based on the compliance of the lung as well as the resistance of the lung and the breath effort, the pressures of the lung will vary. based on a constant flow. That goes for the high flow nasal cannula. The difference with the non-invasive ventilation is when it's delivered, the gas flow is variable based upon the inspiratory needs of the patient. So what that means that you don't have a set inspiratory flow going forward, and based upon the patient's thoracic compliance and resistance, and also the inspiratory pressure as well as the PEEP, you will mainly get an adaptive flow that is set for what the patient wants. Because of this difference between the flow delivery of each device, there's a different physiologic effect on each system, which I'm going to get a little bit more into later, but I just wanted to tell you why that occurs. So let's talk a little bit about oxygenation and PEEP, particularly on non-invasive ventilation, and then I'm going to go into high flow nasal cannula in the next slide. When a patient is in acute respiratory failure, the average inspiratory rate generated by the patient could be anywhere from 30 to 40 liters per minute. So when someone's in acute respiratory failure, their inspiratory effort is pretty high. Sometimes that liter flow can exceed 60 liters per minute if someone is severely ill. So, that's a lot of flow being delivered to the patient, not being delivered, but the patient's inspiratory effort is going that high. The FiO2 that can be delivered with non-invasive ventilation can really go up to 100%, but that's if there was no leaks, and there's always a leak, but you can really generate a high level of FiO2 with non-invasive ventilation, especially if you got the mask on right and you have some leak compensation going on. The PEEP can also be set on the patient with non-invasive ventilation, so you could titrate the PEEP up to where you need. They did an observational study where they looked at 64 patients who had acute respiratory failure, and the level of improvement based upon the PF ratio under NIV was comparable to that of invasive ventilation. So even if you were intubated or used non-invasive ventilation, they felt that during this study you could get an improvement of the PF ratio equal to each type of mechanical ventilation. So that is a really pretty good setting. So obviously non-invasive ventilation can deliver some good PEEP. It could deliver some good inspiratory flows as well as PEEP. So just wanted to throw that out there. Now we're going to be talking about oxygenation and PEEP effects with high flow nasal cannula on the next slide. So let's now turn our attention to the impact of oxygenation and PEEP on high flow nasal cannulas. A high flow nasal cannula can deliver a high FiO2, almost up to 100%, and can also deliver a higher flow rate up to 70 liters per minute. And most of the time, 70 liters per minute far exceeds what a patient's peak inspiratory flow rate, so it'll meet their inspiratory demand. High flow nasal cannulas are much better than your traditional oxygen devices in regard to acute respiratory failure because they give a more reliable FiO2. In regard to PEEP, there's a saying that under perfect conditions, for every 10 liters of flow, you get 1 centimeter of PEEP. But this is based on the fact that maybe the patient's mouth is closed in and there is not any kind of major leak. But typically, the generation of positive pressure or PEEP with a high flow nasal cannula is really not that much. So if you have someone on a flow of 70 liters per minute, at the best, they could have 7 centimeters of PEEP involved. But, due to leaks, that could vary, and there's always leaks. People always talk, people always open their mouth, and so on. Clinical studies have shown less improvement in oxygenation using a high-flow nasal cannula than with non-invasive ventilation. And probably the impact of that is due to the fact of PEEP. For example, a non-invasive ventilation can deliver higher levels of PEEP and more consistent levels of PEEP rather than the high flow nasal cannula, which has some form of PEEP, but based upon the leak, this PEEP can vary from breath to breath. So that is the story of oxygenation and PEEP effect with high flow nasal cannulas. I think you're going to find this kind of interesting. They did some studies of patients who were on non-invasive ventilation versus high flow nasal cannula for acute respiratory failure. And what they found was, because these patients were really breathing heavy and hard, they had some form of lung damage, and they actually labeled this lung damage as self-inflicted lung injury. So basically what they say is, when a patient is hypoxic and they are in respiratory failure, their muscle activity is really high and they have a high respiratory drive, they have a high respiratory rate. And in this situation, they do a lot of spontaneous breathing, but they take these deep, shallow breaths. They got like one's shallow, one's deep. One thing that's in common is they doing it at a high respiratory rate. And they found that due to this increased respiratory rate, increased respiratory drive, there were changes in global and regional pressures. And what this caused was some form of self-inflicted lung injury, and they call it P-SILI. So the goal is to prevent this type of injury, and so oxygenation strategies are really important at this point. So when a patient goes into hypoxic respiratory failure, you really want to do something rather quickly with them. And if you see that their respiratory drive is really inflated or really high, you may want to consider going directly over to non-invasive ventilation or intubation to prevent any kind of lung injury that they may have. It's kind of interesting that they came up with this study, but I've seen some other studies pointing to this too. How many of you heard of a Cochrane review? A Cochrane review is a scientific study. Basically, it's a medical scientific study where they look for different questions and then they look for the supporting evidence. In this particular case, I went to the Cochrane Review website and I looked for high flow nasal cannula breathing in support for the intensive care patient. They didn't really have anything for hypoxic respiratory failure, but they had something there for breathing support in the adult intensive care unit. So the question was, are high flow nasal cannula a helpful treatment option for the adult patient? So they looked at many studies, and they said that high flow nasal cannula can lead to less treatment failure when compared to standard oxygen therapy, but probably makes little or no difference as compared to using non-invasive ventilation. So what they're basically saying is, when you compare non-invasive ventilation or high flow nasal cannula to standard oxygen therapy, it's better to use high flow or an IV. For most other review outcomes, we found no reliable evidence of a difference in effect. But there are 51 ongoing trials, and they plan to include these in their Cochrane review in the future. So once they do that, they might have a different conclusion. But their current conclusion is that high flow nasal cannula and non-invasive ventilation versus standard oxygen therapy is much better than just using standard oxygen therapy like a non-rebreather or a ventimask or so on. So this is just something I wanted to put out there right now, and there's more to come as we move along. I then took a look at the evidence for the use of non-invasive ventilation for hypoxic respiratory failure. And I found some predictable findings with this. As we all know, non-invasive ventilation has been shown to be quite effective for a patient of acute hypercapnic respiratory failure secondary to COPD. So if you're a COPDer and you are retaining your CO2, NIV is a great tool. It's much better than intubation, and you cannot do the same thing with a high flow nasal cannula. Non-invasive ventilation as a general approach to managing respiratory failure in the absence of hypercapnia has shown mixed results. So basically what they're saying is, if you have a patient who has hypoxic respiratory failure and they don't have hypercapnia, the results are mixed. But they found that certain conditions do benefit from non-invasive ventilation, such as pulmonary edema, especially cardiogenic pulmonary edema, patients who are immunosuppressed, post-operative patients, community-acquired pneumonia patients, post-extubation management for those who might predictably fail, and acute lung injury have shown some mixed results. So the bottom line is there are certain medical conditions that result in both hypercapnia as well as hypoxic respiratory failure, such as cardiogenic pulmonary edema, immunosuppression, postoperative management, a community-acquired pneumonia, and post-extubation failure. They may benefit from the use of non-invasive ventilation. So part of the problem is because there's so many different medical conditions with non-invasive, they don't want to use broad consensus saying that non-invasive ventilation should be used for all patients with hypoxic respiratory failure, but certain patients benefit from it. So I thought I'd put this chart out here, and what this chart is the use of non-invasive ventilation for hypoxic respiratory failure, but also those who might be suffering from hypercapnia. So if you are a patient who is a COPDer and you come in with hypercapnic exasperation, absolutely use non-invasive ventilation. Cardiogenic pulmonary edema, use it. Postoperative patients, use it. Palliative care, use it. Immunocompromised patients, use it. Why immunocompromised? They found that the mortality rate of patients who are intubated who are immunocompromised is much higher than using NIV. Now, some low evidence is post-extubation failure. That could be, you could use it or you may not use it. There's some good studies showing with trauma patients and weaning patients who are hypercapnic, the use of non-invasive ventilation. So let's talk about the ones who you should not use non-invasive ventilation. In the prevention of hypercapnia and COPD exasperation, it's do not do it. Post-extubation respiratory failure, don't do it, just intubate them. Acute asthma exasperation, not recommended. New form of respiratory failure, they don't know the underlying reason for, don't do it. Pandemic viral illnesses, don't do it. So this is some of the evidence out there. They did some studies, and I just wanted to share this with you right now. Let me give you some clinical practice guidelines for the use of non-invasive ventilation in the management of hypoxic respiratory failure. They have this term called de novo, and de novo means that it is hypoxic respiratory failure that happens acutely in the absence of a chronic lung disease or cardiac failure. So if you have no kind of cardiac history, no kind of chronic lung disease, they call that de novo hypoxic respiratory failure. The American Thoracic Society and the European Respiratory Society, they have no kind of guidelines for the use of non-invasive ventilation in the management of de novo hypoxic respiratory failure. So what's an example of de novo hypoxic respiratory failure? We know the definition, but what is an example? If your PF ratio is less than 200 and your respiratory rate is greater than 30, that could be the cause. Now, what kind of condition could cause that? It could be sepsis, it could be atelectasis, it could be pneumonia. So, but none of those conditions are considered chronic. They are just considered acute. So they recommend not to use non-invasive ventilation in these particular patients. So let's now turn our attention to some known benefits of non-invasive ventilation for hypoxic respiratory failure. As I mentioned earlier, patients with cardiogenic pulmonary edema, post-operative patients, and trauma patients all benefit from the use of non-invasive ventilation for hypoxic respiratory failure. The largest study to date found no difference in intubation rates or mortality when comparing NIV versus CPAP or standard oxygen therapy, which is kind of curious. But I would say in most cases you want to use non-invasive ventilation, especially those with hypoxic respiratory failure, cardiogenic pulmonary edema, postoperative patients, and also trauma patients who have lung contusions, maybe some kind of trauma to the lung. Let's explore some known benefits from non-invasive ventilation for hypoxic respiratory failure. So the first patients we're going to talk about is post-operative setting patients, those who had lung resection or abdominal surgery. What they found with the use of non-invasive ventilation, lung resection subjects have significantly reduced need for intubation and hospital mortality. So the use of non-invasive ventilation in this particular group was good. Subjects with abdominal surgery have significant lower intubation rates with NIV and lower but not significant 90-day mortality. So in these two particular groups, lung resection and abdominal surgery, non-invasive ventilation is really called for, especially if you have hypoxic respiratory failure. In trauma patients, it's more specific to those who have chest trauma. Think of pulmonary contusion. Think about someone who's in a car accident who crushes their chest. Pooled analysis found lower intubation rates, lower mortality, less nosocomial pneumonia, and shorter ICU stay when using NIV versus intubation or any other method. And the third group that really benefits from this is cardiogenic pulmonary edema, who typically are hypoxic, and where you can put them either on CPAP or non-invasive ventilation, and this works very well. So in these particular patients, I would use non-invasive ventilation more than I would use high-flow nasal cannula, because this particular sector of patients is gets much more benefit out of it. So let's talk about non-invasive ventilation and hypoxic respiratory failure when the benefit seems a little less clear. There are certain patients who suffer from acute hypoxic respiratory failure who don't respond well to non-invasive ventilation. The failure rates based upon the etiology of their illness is anywhere from 25 to 87%. Now, as I mentioned on the previous slides, there are certain conditions which have been shown to work very well. But, you as a clinician and the physician as the person in charge, you got to be very judicious about when to treat someone with NIV for acute hypoxic respiratory failure. Now, here's a thing when we talk about failure rates. Like I said, there's a high percentage of failure rates with non-invasive ventilation. A lot has to do with compliance. A lot of people who are on non-invasive ventilation are non-compliant with it and want to take the mask off. So I wanted to mention some of the risk factors involved with failure for non-invasive ventilation, and hopefully you could apply this to your practice at the bedside. So now let's explore some of the risk factors for failing with non-invasive ventilation, and you should be aware of them, because if you keep someone on non-invasive ventilation too long, the likelihood of their having a higher mortality is quite real. So let's talk about it. So let's talk about some tools that could be used to monitor the patient on non-invasive ventilation to see if they do well. One of the best tools you could look at is the PF ratio. And the PF ratio is the PaO2 over FiO2, and it comes up with a numerical value. It is a great tool to determine hypoxemia in the patient, and it also is used to classify acute lung injury in ARDS. For example, if someone is in ARDS, their PF ratio is less than 200. For someone who's in ALI, acute lung injury, it's less than 300. And, just because you put someone on 100% FiO2 or 60% FiO2, you really got to measure the PF ratio to get a good understanding of where they're at. In regard to non-invasive ventilation, a lot of studies have shown that if you put a patient on non-invasive ventilation and you look at their PF ratio at 1 hour, and if their PF ratio is 200 or less, the likelihood of them failing is great, and the likelihood of their mortality is going to go up. So basically, the best thing you could do is if you put someone on non-invasive ventilation and you're monitoring their blood gases and you look at the PF ratio, if their PF ratio after 1 hour of being on non-invasive ventilation is 200 or less, you need to get them off non-invasive ventilation and you need to intubate them with them using PEEP. So that is a telltale sign that you can see if someone's failing. You put them on non-invasive ventilation, you look at the PF ratio before they went on, you look at the PF ratio at 1 hour after being in it. If you don't see an improvement, try something else. Maybe intubation is where you got to go. And if you see the PF ratio being under 200 after 1 hour, you don't even think twice about it. You need to intubate them. Regarding non-invasive ventilation failures, another tool that you could use besides the PF ratio is looking at severity scores. And if you're not familiar with severity scores, these are scores that are determined. The patient gets evaluated upon admission to the hospital on the first day of admission. So what that means is on the first day of admission, they look at the age of the patient, they look at the weight of the patient, they look at their comorbidities, they look at their BMI, they look at their blood gases, they look at their previous history. They look at many different variables such as heart rate, blood pressure, diabetes if they have it, and they come up with a score based on how sick they are and what age. So for example, if someone comes into the emergency room with appendicitis and they're really sort of suffering, and one of those patients happened to be 29 years old, in good health up to this point, no diabetes, no hypertension, and then someone comes into the emergency room again with appendicitis, but they are 60 years old, they are overweight, they have hypertension, they got diabetes. Even though they both have appendicitis, each of them will have a different severity score. And based on that severity score, you can almost determine their morbidity and mortality in the hospital. So why is this useful? Because if you're going to put someone on non-invasive ventilation, the outcome of the patient could be based upon the severity scores. Now, I could spend a whole lecture talking about severity scores because it is quite interesting. But some of the most common severity scores is the SAPS-2 score, which is Simplified Acute Physiology Score 2. We have another one called the SOFA score, which is Sequential Organ Failure Assessment. And finally, we have an Acute Physiology and Chronic Health Evaluation 2, which is commonly known as an Apache score. So knowing the severity scores of a patient when they come into the emergency room based upon their comorbidities and age and other factors, you may or may not want to put them on non-invasive ventilation because the likelihood of failure is greater. On the next slide, I'm going to show you a couple of graphs of these severity scores. To follow up on the previous slide when we were talking about severity scores, I have two scores listed here. One is the Apache 2 score, and the other one is the SAPS 2 score. So the top one is the Apache 2, and the other one is SAPS 2. The funny part is each of these scores list the same variables. In other words, you look at the Glasgow Coma scale, you look at the age, you look at the severity of the illness, you look at their diabetic, look at their hypertension, look at their heart disease, look if they have any kind of lung disease like COPD or anything else. And based upon that, you come up with a score. So anyone that comes in the emergency room, for the example I gave before, like appendicitis, you might have two people come in with the exact same diagnosis, but each can be a different age, and each of them can have different severity scores. So why is it important? Because if you have someone who has a high severity score, you may want to not put them on non-invasive ventilation. You may want to put them you might want to intubate them, because the likely of survivability is greater with intubation than it is with non-invasive ventilation. But if you have someone with a low score, you could easily put them on non-invasive ventilation if they are hypoxic. So, for example, in the Apache 2 score, if you have a score of, let's say, 10 to 14, your hospital mortality rate is 15%. Now, if you have a bunch of comorbidities and your score turns out to be 25 to 29 and you have a 55% mortality, you may just want to intubate that patient because their Apache 2 score is so high and the likely of survivability on non-invasive ventilation is not that good, but they would do better with invasive ventilation. And the score below is similar to that. That happens to be the SAPS 2 score. And as you can see, the graph on the bottom, the predictable mortality rate goes up as the number of points going up. So it's almost similar to the first Apache 2 score. You have to pick and choose who would go on non-invasive ventilation, and if their severity scores are high, you most likely benefit from putting them on invasive ventilation. And I just wanted to throw it out because these are other risk factors for non-invasive ventilation. Another risk factor for non-invasive ventilation is monitoring the exhale tidal volumes. And you may say, how important is that? It's very important. Most BiPAP devices have a single limb circuit. And the truth is, these single limb circuits are not the most accurate at measuring exhale tidal volumes. They're not as accurate as, say, putting non-invasive ventilation on a servo or putting non-invasive ventilation on a Draeger ventilator. Because why? Because they're dual limb circuits. Dual limb circuits can measure tidal volumes much more accurately than a single limb circuit. And the biggest reason the single limb circuits don't do a great job at measuring exhale tidal volume is because of leaks. So they did some studies where they were looking at exhale tidal volumes and NIV failure. So basically, they were measuring the exhale volumes of these patients on non-invasive ventilation and seeing if they had a high failure rate. And what they found, that if the patient had an exhale tidal volume of 9.5 milliliters per kilogram of predicted body weight, that this predicted NIV failure up with the sensitivity and specificity of 82 and 87%. So really accurate measurement of failure if you happen to be exhaling tidal volumes of 9.5 milliliters per kilogram based on predicted body weight. Another measurement, another finding from this study was a tidal volume of 9 milliliters per kilogram of predicted body weight at 1 hour after being on non-invasive ventilation. So if you put someone on NIV and you measure the exhale tidal volumes after 1 hour and they're 9 milliliters or better per kilogram of predicted body weight, you better intubate them because the likelihood of failure is tremendous. And you may ask, why is tidal volume such an important factor? And this is because most patients who go on non-invasive ventilation for hypoxic respiratory failure have a very uncontrollable breathing cycle. They might hyperventilate, they might take some deep breaths, they have a lot of difficulty controlling their respiratory drive. And one way to objectively measure this is to look at their exhale tidal volumes. So exhale tidal volumes is a good tool to use in regard to NIV failure. Another group that you got to watch after on using of non-invasive ventilation is the community-acquired pneumonia group. A lot of times patients come into the emergency room and they are diagnosed with community-acquired pneumonia, and rather than intubate them, they put them on non-invasive ventilation if they're hypoxic. So this is a case of patients who are in hypoxic respiratory failure due to the fact that they got a community-acquired pneumonia. And in this particular case for community-acquired pneumonia, they've done some studies where they found that if the patient has infiltrates found on a chest x-ray worsen in 24 hours after being on NIV, do not delay intubation in this group. So what they're saying is, you could put them on non-invasive ventilation to see how they're doing for the hypoxic respiratory failure. And normally patients turn out pretty good, but if you look at their x-ray at the time they go on the BiPAP and then you look at 24 hours later and the x-ray is worse, stop the non-invasive ventilation and intubate them, because the studies show that the likelihood of failure and the likelihood of their morbidity going up is really high. So this is another group you should look for. So let's talk about a patient with ARDS who come into the emergency room, who you get a blood gas and their PF ratio is not too good. So they did a big study. It's called the Lung Safe Study, and they were showing evidence that non-invasive ventilation is commonly used in patients who meet ARDS criteria. For what's the ARDS criteria? If you have a PF ratio of less than 200 and you put someone on non-invasive ventilation, the likelihood of them failing is greatly increased. So, bottom line, don't put ARDS patients on non-invasive ventilation if their PF ratio is less than 200, especially if they got odds. They also did some studies showing if you had patients with a PF ratio of 150 had a higher ICU mortality if they were treated with non-invasive ventilation rather than being treated with invasive ventilation. So in other words, you have someone come into the emergency room, their PF ratio is less than 150 or less, and you decide to put them on non-invasive ventilation. The likelihood of them dying is greater than if you intubated them right away and used invasive ventilation. The likelihood of survivability is much better. They also found that NIV interface failures were a common thing. In other words, patients who had oral nasal masks commonly led to failure. So in other words, in this particular group of patients, if you use the interface of an oral nasal mask with non-invasive ventilation, it commonly led to failure. But they also did some studies looking at the helmet mask, and what they found, it was better than the oral nasal mask because it can deliver higher levels of PEEP. It actually had improved tolerance with the patient, and the patient could stay on this type of ventilation a little bit longer. So a helmet mask, they're doing some new research out there. I don't have the most current research for this particular presentation, but maybe I'll put something together. But they've done some successful studies with patients going directly to a helmet mask who have ARDS with non-invasive ventilation, and the reason behind that is they can deliver higher levels of PEEP, they have better patient tolerance, and they have longer sessions where the patient doesn't take the mask off. So let's talk about patients who are immunosuppressed. Who's immunosuppressed? HIV patients, chemotherapy patients, people with some kind of genetic disorder where their immune system isn't working. So when these patients come into the hospital because they got hypoxic respiratory failure, you may want to use non-invasive ventilation in this particular group before intubation. Why? Because if you intubate somebody, the likelihood of introducing a pathogen into their sterile lung is greater. So patients do much better with non-invasive ventilation in this particular group, but maybe high-flow nasal cannula could be better in this particular group. And I'm going to be talking about high-flow nasal cannula in a few slides from now. So, I just mentioning all the cases where non-invasive ventilation could fail. And with all those tools, they came up with a tool called the HOCKE score. Basically, what that is that you look at the heart rate, you look at the pH, you look at the Glasgow Coma scale, you look at the PF ratio, and you look at the respiratory rate. And based upon your score, you could determine whether your NIV is going to be successful or failure. So, for example, if your heart rate's greater than 121, you get 1 point. If your pH is less than 7.25, you get 4. If your Glasgow Coma scale is 11 to 12, you get 5. You could read the chart. So based on your score, it could really determine whether the probability of NIV failure. What they found with this study, a HOCKE score of 5 after 1 hour of treatment had a diagnostic accuracy to predict failure of 82%. So think about that. So you could objectively add these scores up, look at the patient on NIV after 1 hour, and if their score was 5 or greater, they have an 82% chance of failing, which is a really great tool. It's a very objective way of looking at a patient to see how well they're doing. The last slide wasn't that good at looking at the values, so I wanted to put another shot at this at looking at the values so you might see it better. But I think you get the idea. You look at the heart rate, you look at the pH, you go look at the Glasgow Coma scale, you look at the PF ratio, you look at the frequency. If the score is 5 or greater after 1 hour of being on non-invasive ventilation, you better intubate them because they have an 82% chance of failure. You know, with all I've been showing you, I wanted to show you the risk of a higher mortality if you delay intubation in certain groups of non-invasive patients. So I'm going to go over this a little bit as a recap. Regarding NIV failure for hypoxic respiratory failure, the most important thing you could do is monitor the patient during this time. I've shown you a tool, the HOCKE tool. I've shown you some parameters, different types of conditions where it can impact the patient. If the patient is not successful on non-invasive ventilation, do not delay intubation. Studies have shown that if you delay intubation, you increase the mortality of these patients. So you give them an hour, you give them 2 hours. Don't give them 24 hours of struggling on non-invasive ventilation, then intubate them because you increase their mortality. I want to drive home the point about delaying intubation. So you have a patient come in the emergency room, they are in hypoxic respiratory failure. Your choice at this point is to put them on non-invasive ventilation. And you put them on and you're monitoring the blood gases and they're just sort of borderline and you keep them on and you keep them on. The longer you keep someone struggling on non-invasive ventilation, the greater likelihood they're going to die. So timing to intubation can be life-saving. If you keep a patient on non-invasive ventilation too long, hoping for a better outcome, you're hoping that, oh, they're going to get better. Wait, let's give them 24 hours. Studies have shown that you increase the mortality of these patients. So you have to be careful about patient selection. All the cases I just mentioned earlier, who benefits, who doesn't, you got to make that a priority in your decisions. Also, once you put a patient on non-invasive ventilation, you should be using the HOCKE score to time your intubation, because if you put them on non-invasive ventilation and their HOCKE score after 1 hour is 6, don't delay. You know, there's no reason to keep them on for 2 hours. This is a basic slide of setting up non-invasive ventilation and what you got to do. Remember, the positive pressure applied to each patient needs to be individualized. In other words, IPAP pressure, you could start everyone over at 12/6 or 10/5, but you have to be looking at exhale tidal volumes, you have to be looking at the blood gas, you have to see what kind of pressure is required to ventilate that patient. So positive pressure has to be individualized, and so I'm talking about IPAP pressure. Regarding EPAP, EPAP improves oxygenation. EPAP is PEEP. So you really got to use this judiciously and if someone comes in with hypoxic respiratory failure, maybe an EPAP of 4 or 5 ain't going to do it. Maybe you have to increase it. And you know the delta, you know, IPAP over EPAP is pressure support, the difference between it. So you got to come up with the right number. Studies have shown that in non-invasive ventilation, you really don't want to put the EPAP greater than 10. 10 should be the upper limit of your EPAP setting. Obviously, as I mentioned earlier, the helmet interface has been shown to be better at maintaining PEEP. So you might want to use a helmet on hypoxic respiratory failure patients, because you could actually improve the outcome of these patients with compliance, staying on, and actually generating better PEEP. And finally, humidification in these systems have been shown to improve tolerance and comfort with the patients. So, dry gas going in at 30, 40, 50 liters per minute versus some humidification. Humidification is good on non-invasive ventilation. So these are some general guidelines, and I'm not telling you how to set up a BiPAP. I'm sure you know how to do that. Now that we covered non-invasive ventilation for hypoxic respiratory failure, let's turn our attention to the role of the high-flow nasal cannula in this particular group. So I went back to Cochrane for looking to see if the high-flow nasal cannula was used for breathing support in the adult intensive care unit. And the conclusion they made at the time of this presentation, there was not enough quality evidence to determine whether high-flow nasal cannula can offer a safe and effective way of delivering respiratory support in the ICU. But there are exceptions. So they are doing some new studies out there, and they might update the Cochrane review, but the current status as of the time I put this presentation together, it was not really advised to do so. This is an interesting slide in regard to high-flow nasal cannula. They were looking at the utilization of high-flow nasal cannula for hypoxic respiratory failure. And it has gained tremendous popularity. I mean, there's a lot of hospitals using it, there's a lot of ICUs using it, but there's not such good studies out there. But one study that came out was called the Florali study, and what they did is they compared the use of high-flow nasal cannula, non-invasive ventilation, and standard oxygen therapy for patients who came into the ICU for acute hypoxic respiratory failure. And what they found was that the mortality rate was lower with the high-flow nasal cannula group, which is promising. I don't know the exact details of how the patients responded, because they basically thought they didn't really go over the response to it as much as they went over the mortality of these patients. And the 90-day mortality was lower with the high-flow group. So let's further our conversation about high-flow nasal cannula for hypoxic respiratory failure. There are many conditions that could cause hypoxia, such as trauma and stroke. It could be respiratory disease, it could be unstable angina, it could be multiple organ failure, it could be cancer. There's a whole list of them. And whether to put a patient on non-invasive ventilation versus high-flow nasal cannula is a clinician's choice. But where is the evidence? What is the evidence of this that's going to happen? So in 2020, there was a study by Doshi, and Doshi randomized patients doing a trial, what is called a non-inferiority trial of 204 subjects, and they compared the use of high-flow nasal cannula versus non-invasive ventilation, and they found that high-flow nasal cannula was non-inferior for the treatment of acute respiratory failure. So basically, they found it to be equal. The problem was within the study that there was a lot of crossover. So in other words, if a patient didn't do too well in high-flow nasal cannula, they switched them over to non-invasive ventilation, which sort of clouded the results of the study. So currently, they feel there's insufficient evidence to support the use of high-flow nasal cannula instead of an IV to treat all forms of respiratory failure. And regarding the Florali study, I think, was done from 2015, 2016, and they did a study where they looked at a group of patients who were immunocompromised, And they found in this particular group, with the use of high-flow nasal cannula, they had lower intubation rates, lower mortality within this group. So with the subset of immunocompromised patients, they have shown that the high-flow nasal cannula was superior to non-invasive ventilation, which is something we should keep in mind. This is our summary slide. Now, what we were doing during this presentation is we were comparing non-invasive ventilation versus high-flow nasal cannula in hypoxic respiratory failure in this particular group. And you know, there's a lot of studies on non-invasive ventilation because it's been out a long time, and they're doing a lot of new studies on high-flow nasal cannula. So even as I expressed the current evidence out there, there might be a drive to start utilizing high-flow nasal cannula. So non-invasive ventilation generally is the tool to use in regard to hypoxic respiratory failure. Avoiding intubation is a real key factor for the utilization of non-invasive ventilation. So a lot of experienced clinicians can utilize non-invasive ventilation for acute hypoxic respiratory failure, but they really need to understand the risk factors. Like, you don't put someone on non-invasive ventilation for over an hour if their PF ratio is 200 or less. The high-flow nasal cannula is increasing use in the ICU. A lot of people have been using it in the ICU successfully, but there's not a lot of good studies out there showing its full support. But there are new stuff coming out. But there are certain populations, as I mentioned earlier, that do very well with high-flow nasal cannula. So I would say utilizing both the high-flow nasal cannula and the non-invasive ventilation is a good tool to have. You know, you could use both if you need to. But, you know, certain conditions such as immunocompromised patients do much better with a high-flow nasal cannula. And I know there's going to be some new research coming out on new stuff for the high-flow nasal cannula. And when it does, I'll put a new presentation together for it. I want to thank you all for joining my presentation, and I really appreciate you coming. I listed some references for you. There are many more that I have, but you know, for the sense of you know, how much you want to see on one page, I decided to just put a few, which are all very good. And again, I thank you, and I hope to see you in the future.